Hello and welcome everyone to the Women in Wellness Series Part 2 that is being co-presented by both Ellevate and Wellness. I'd like to do a quick introduction today for our guest speaker, who is Susan Prendergast. Welcome, Susan.
Thank you. Hello, everyone.
Lovely to see you again.
Love you
Susan is here from Ellevate Healthcare, who is an ATB client, and we are obsessed with our customers and love to amplify our clients. Ellevate Healthcare is focused on women's health, specifically menopause, fertility, physical examinations, bioidentical hormone replacement therapy, things we learned a lot about in part 1 of our series. And much like ATB, they really listen to their patients and clients, and they set up appointments that are a minimum of an hour long, and also via Skype and FaceTime. So very inclusive to any of our team members out there, even if you don't happen to live in the same city as Susan. So Susan is our guest speaker today, and I'd also like to introduce and welcome our moderator, who will be sliding over in a second. Our moderator today is Rachel Wade. You know her as a communications manager, also soon to be a director of equity for diversity markets. So please enjoy both Rachel's moderating and Susan's presentation.
Thank you, Tara. So I'm moderating this today because I have a personal stake in this discussion, in that I myself have to deal with hypothyroidism on a regular basis throughout probably the rest of my life now. And for me, this is a really important topic because I was really lucky that I even found out I had this. And as I started realizing that I had this condition and kind of going through the process of how to fix it, I talked to my other female friends, and a lot of other people had the same story as me, where they didn't realize they had it, and it was sort of by accident that they found out that they had hypothyroidism, and then it kind of changed their life once they were able to diagnose it and deal with it. I found out because one of my best friends found out she had hypothyroidism only because she got pregnant, and when they did all of her blood work, that's how they discovered it. So she started sharing some of the symptoms that she realized she had after the fact when she had been diagnosed, and I kept thinking, some of these seem to line up with what I had. I've been really struggling with constant weight gain, and I couldn't lose it. It didn't matter how well I ate, if I exercised. I might be able to maintain the weight at the highest weight I'd ever been, but I certainly couldn't lose the weight. And if I wasn't watchful of my diet or exercise, even just a little bit, I would continually gain weight. So this was a concern of mine, and after hearing about my friend's condition, I decided to look up what the other symptoms are. And I posted them on the Ellevate page, what some of the common symptoms are. And as I had Googled this and started going down the list, I realized I had almost every single symptom on the list. And as we do, I think as people, I had chalked up most of these symptoms as being individual things that were just quirks in my life, not a big deal, something I could deal with. But taking it down the list, I had weight gain, I had a slow heartbeat that I regularly had doctors comment on. I had constant fatigue. It got to the point where I almost couldn't get through the day without having a nap. Like I physically couldn't make it without having a nap. Extreme sensitivity to cold. Oftentimes, if it was cold and I'd gotten cold by going for a winter walk or something like that, I had to actually take a hot shower to warm up again. It was the only way I could get heat back into my body. Definitely a little bit on the depression side and irritability, which you often chalk up to what space you're at in life or what's going on around you, instead of thinking that it might just be a part of what's going on inside you. And then because I'd actually done an undercut on my hair, I realized I had these huge patches of dry spots that I hadn't noticed before, where my hair had been obviously covering that space. So I also had the dry skin issue, and also abnormal menstrual cycles. That had become a regular thing for me. And again, I just sort of chalked it up as a different phase in my life and just part of being. So when I saw the picture of all of these different symptoms that I could relate to in a list, I realized there was probably an issue. So I was a little bit disappointed that my doctor hadn't caught this as well, and that I've had the same doctor for a really long time, and a lot of these things I'd mentioned separately in different occasions, but there wasn't really any connecting of the dots. However, when I asked specifically if I could get tested for hypothyroidism, she was fine with it, and they sent me for my blood work, and lo and behold, we discovered that that was an issue in my life. So I've been on Synthroid ever since, and it's like a miracle pill. My energy levels are back where they're supposed to be. I lost about 10 pounds almost instantly. I mean, not overnight, but very quickly. And now I'm able to start managing weight loss and things like that as well. I can get through the day without a nap. My dry skin is gone. My menstrual cycles are normal again and predictable. So it really changed a lot for me in my life. And while they might all seem like small things on their own, when there's so many things that add up and you can actually fix that, it's really important that we do. And there's a lot of women that this affects, and I don't think it's regular enough in our blood work and the things that we're asked to do for our annual physicals or whatever it is as it should be. So I think that this is a great session, and I'm really grateful that Ellevate Healthcare is offered to do this session today, because I really advocate that women get this check. Even if you have a few of these symptoms, it's just a blood test. Ask your doctor to do it. If they're uncertain, I mean, just own your own body and put the pressure on that you want to know. So on that note, thank you everybody who's agreed to attend today. I hope that this is enlightening for you, whether you think you might have thyroid, whether there's someone in your life dealing with this, and trying to figure out what the correct dosage is for them, which in and of itself is a bit of a journey. Or whether or not you know that you have thyroid and you just want more information about it, such as myself. So on that note, now that I've shared a little bit about my story, I'm going to pass it over and let's hear the facts.
Okay, so I think we're going to put up a set of slides, but first of all, I'll just say hello and thank you for having us back again. We're going to be focusing on talking about the thyroid and common problems with the thyroid. It's going to be, like the last time, a bit more of a medical discussion versus, you know, I think people were pretty happy the last time with the level of medical talk, but if it gets to be too jargony, then just shout out. But yes, and if you have any questions along the way, there is a chat room open, so you can certainly send in your questions, and I'm going to try to get done as soon as I can so that we have lots of time to answer questions. So if you put up the slides, we will get started. Just let me know when you're ready. All right. So like I said, we're going to be talking about thyroid problems and understanding the symptoms and what's happening in your body should you have a concern. So if you could put to the second slide there. So I'm going to quickly review how the thyroid works and what it does in the body. I'll talk about hypothyroidism and hyperthyroidism and the reasons why these problems should be treated. And then finally, I'll talk about treatment options. I'm also going to be speaking a little bit about what you should be having done or looked at should you want this included in your annual exam. So thank you, Rachel, for bringing that up. Next slide. So how does the thyroid work? The thyroid is a really important organ in the body. It doesn't work alone. There's a very intricate feedback loop that happens between the hypothalamus and the pituitary gland in the brain and the parathyroid and thyroid glands that are in the front of your neck. The thyroid is attached to the lower part of the voice box and to the upper part of the windpipe or trachea. It has two lobes, and the lobes are connected by a narrow bridge called the isthmus. Each lobe is about 4 centimeters long and about 1 to 2 centimeters wide. And every year during your annual exam, this should be palpated by your care provider. Oftentimes when people have issues with their thyroid, palpation will determine whether or not we need to investigate a little bit further as to what's going on. So as part of the feedback loop, the hypothalamus releases thyrotropin releasing hormone, or TRH, which stimulates the release of thyroid stimulating hormone, or TSH, and prolactin from the pituitary gland. Many of you will probably know about TSH because it's one of the most common things that people talk about around the thyroid, and it's only one part of the picture. I'll get into talking a little bit more about that in a second. Thyroid stimulating hormone signals the production of T4 and a small amount of T3 to be released from the thyroid gland. 80% of T3 is derived from T4. So even without a thyroid gland, you can still produce T3 and T4. Any problem you might have with the hypothalamus, the pituitary, the parathyroid, or the thyroid can affect thyroid hormone production and function. So if you could go to the next one. Thyroid stimulating hormone, TSH and T4, are hormones that are essential for life and have many effects on body metabolism, growth, development, temperature, heart function, blood pressure, muscle tone, production of other reproductive hormones. T3 and T4 are the two most important thyroid hormones as they influence all of these things, each and every one of them. Next one. So when a person might have an issue with their thyroid or with the production of T3 and T4 in particular, it can be many, many reasons as to why this might happen. One of the most common is basically just a genetic or unexplained. Most times this happens to women later in life, so as you age. And it wouldn't happen when you're pregnant or in the postpartum period. It wouldn't happen after an illness. It just happens as you age and your body becomes less able to produce the hormones that it should. A very common reason. The next would be perimenopause or pregnancy. What happens when we have a pregnancy or in the postpartum period or when we start to go through menopause, our reproductive hormones will influence thyroid production and vice versa. So it sets that feedback loop of hormone production into a very disbalance. Another reason is an inflammation in response to an illness. And this is the most common reason for sudden change to our thyroid function. And I'll get into the disease names in a few minutes. Other less common reasons for thyroid problems would be radiation exposure, medications that can affect the thyroid, cancer, and other diseases. So the state of the normal thyroid function is called euthyroidism. So if your thyroid is working perfectly, whether you're treated or not treated, it's called euthyroid. Unfortunately, when people look at blood work results around the thyroid, there's a range that determines if we are euthyroid. And as long as you fall in that range of TSH, which is between 0.2 and 4.0, most people won't treat the thyroid. The problem is that that number, that range, is based on studies done with men aged 17 to 70 years old who were in hospital. So it doesn't reflect women's thyroid function. That's not something that a lot of people know. So when you start to have a discussion with your provider about your blood work results, them interpreting your thyroid function based solely on TSH and the range of 0.2 to 4 is inadequate. We want to be looking at how you feel in conjunction with that number. We also need to be looking at levels of T3 and T4, as mentioned before. So when you're asking for your provider to be looking at thyroid function, they should also be including T3 and T4 in the blood work, as well as something called antibodies. So you can produce thyroid antibodies if your body has been ill and you have an inflammatory response that's happening with your thyroid. These types of inflammatory responses are called one of two things, either Graves' disease or Hashimoto's. And so you can become either hyper or hypothyroid when you have an inflammatory response that has made you either one or the other. Specific to Graves' disease or hyperthyroidism, this happens when the thyroid stimulating antibody is produced in the body because of an inflammatory process, and it stimulates the thyroid cells to grow large and produce excessive amount of thyroid hormone. And it's not necessary, but it's just overstimulating the thyroid. It is very, very, very difficult to treat Graves' disease. It's one of the hardest things to treat. So if you do have hyperthyroidism and it's Graves' disease reason, you need to be getting involved with a specialist or someone at least who knows how to deal with this disease. Graves' disease or hyperthyroidism resulting from Graves' disease is fairly common. It's about 1 in 100 of the population, whereas the opposite situation, an inflammatory response in the thyroid that causes hypothyroidism, Hashimoto's thyroiditis, is more common. And I would say in my practice, it's about 50% of my population that has thyroid problems has Hashimoto's. You can't determine if you have Hashimoto's or Graves' disease unless you check for antibodies. So you need to be checking your TSH, your T3 and T4 to make sure they're in balance. But also to ensure that you're getting the right diagnosis, you have to check antibodies. Am I going too fast, or should we stop for questions? I'm going to change a little bit now to talk to more practical symptom stuff, but if you guys have questions about the medical stuff, you can shoot.
I think now's a great time to pause and answer some questions if you
Sounds
don't.
Good.
So one that's, I'm working backwards a little bit here, but I will ask you a few others. Just this one correlates to what you just mentioned. And this was from Tracy, sorry. This was from Sharon Doyle, and she's asking, so as well as Donazon. So are Graves and Hashimoto both hypothyroidism? And so what's the difference between that then and hypothyroidism, I guess?
Okay. So you can get hypothyroidism just from genetics. You can get hypothyroidism from being postpartum. You can get hypothyroidism from another medical condition. You can get hyper and hypothyroidism from multiple things. The most common cause of hypothyroidism is Hashimoto's disorder. The most common cause of hyperthyroidism is Graves'. They're different. But I wasn't going to add this in, but I will now. You can also have hypo and hyper Hashimoto's and hypo and hyper Graves' because they both swing. It's the body's response to trying to regulate based on an under or overactive thyroid gland. But if you do have either of those diagnoses, some people will present, especially with Hashimoto's, with significant hypothyroidism. So they feel tired and slow and sluggish and brain fog, but they might have gone through a period of being hyper. So they were feeling really, really good, and then they swung to feel really bad. It's just that thyroid's attempt at balancing itself. So hopefully that answered that question. They're very different diseases, but they're both rooted in an inflammatory response. Unfortunately, once you have those diagnoses, you never get rid of them. You can never fix an inflammatory thyroid. You can just manage it.
And so are they the same test to check for all of these?
Yes. Yeah.
Okay.
TSH, T3, T4, and your antibodies.
Great.
Absolutely.
Another question that came in from Donna Zons, and there was some significant interest after this question came in, was are vision issues common?
Yes, they can be. So we're going to get to symptoms in a minute. So maybe we'll just park that one for a second, if that's okay. We're going to do symptoms right away here.
Sure. So I guess it's a great segue into that, and you don't, I guess, necessarily have to comment on these since you'll be getting there. But some other comments that came up around symptoms were my thyroid symptoms were chalked up to perimenopause. So that was from Sharon Doyle. Another participant, Jessica Chohan, said, I was told I was depressed.
Yeah.
So there are some comments coming in around that, around symptoms and how it's being diagnosed.
Yes.
As well, there's a question which was for me, so I'll answer this question, but then hand it over to you. Did you debate synthetic versus natural medication? And that was from Carol Schmeigel, and I did not. I don't think I understood that there were many natural options, and I know most of my friends and people that I know in my network who have this definitely treated it using Synthroid. But I'm going to pop that question over to you to see if there's any thoughts that you have around synthetic versus natural medication.
Absolutely. And I will get to that because it depends on your the reason for your thyroid problem, whether Synthroid versus the natural or desiccated thyroid would be the drug of choice. And again, this isn't something that most family physicians or even endocrinologists actually have discussions about. People are starting to get more on board with the desiccated or the natural thyroid, but we will definitely get into that in a few minutes. So I think we'll move forward, if it's okay, and talk about the differences between hypo and hyperthyroidism and then the symptoms, okay? Just knowing that regardless of your diagnoses, your thyroid either is hypo or hyperthyroid. Hypothyroidism is the most common. It's when your thyroid gland does not respond well to the thyroid stimulating hormone, or it can't produce the T3 and T4 at the levels that it needs to. So it overworks And you end up getting this elevated level of TSH, or thyroid stimulating hormone, but low levels of free T3 and free T4. So you get the symptoms of not having enough T3 and T4 in your body. And when we get to talking about the symptoms, that will become clear. But if it affects metabolism, temperature, neurological and ophthalmologic problems, you could see that it slows everything down because you don't have enough of that T3 and T4 to stimulate that really good metabolic and energy production responses. With hyperthyroidism, it's the complete opposite. You get overreactive or better production or overproduction of T3 and T4. So you get a hyperreaction or a hyperstimulation of that energy and metabolism pathway. So you get higher heart rates, higher blood pressures, more anxiety versus depression. You get more weight loss versus weight gain. So it's the complete opposite. We see hyperthyroidism less often because when our thyroids are affected, for whatever reason, through disease or disease process, it slows down production of the T3 and T4 versus speeding it up. The only time when we see hyperthyroidism is if you've got Graves' disease, you're in a swinging phase between hyper and hypo, going towards the hypo, or if you're very, very ill and you have multiple organ problems, you may have hyperthyroidism. It's actually a medical emergency. So for our Graves patients, we are constantly tracking their symptoms and how they feel, because if they start to demonstrate symptoms of hyperthyroidism, we're worried that they're going to need emergent intervention. So very, very different disease. The symptoms that you guys have talked about obviously fit in the category of hypothyroidism. So I'm just going to briefly address hyper, and then we're going to move on and talk mostly about hypo. So again, if you're hyperthyroid, you get racing heart, trouble sleeping, anxiety or anxious feelings, weight loss or difficulty keeping weight on. Some people will get bulging eyes. Some people will get a lump in their throat because their thyroid is producing so much T3, T4 that it just can't get it out fast enough. So it's a very different situation and very different symptoms. Moving on to hypothyroid, if you move to the next slide for me, you can see on the left-hand screen, these are the most common symptoms women and men will explain. So they'll talk about weight gain or an inability to lose weight or maintain weight. Thank you, Rachel, for your honesty. Constant fatigue and tiredness. And some people that come to me don't explain it as tiredness, but as a brain fog. So they feel like they're walking through mud all day long and they just can't get themselves together. And for me, that was my main symptom. I felt like I was walking through life and I wasn't fully aware of where I was at any one moment. And I would suddenly wake up around 2 or 3 in the afternoon and feel, okay, I'm ready to go now. For others, it's that, you get that morning kind of rush and then you just lose it at 2 or 3 in the afternoon. You just can't seem to keep going for the rest of the day. Hair loss is common, dry, flaky skin, depression or low mood. And then for a lot of women, especially if they're in their later years, so when you start to go through perimenopause and menopause, this muscle and joint pain becomes a real issue with hypothyroidism. So many of the women that come to see me for menopause care, perimenopause care, and they have joint pain, I'll look at their thyroid as part of that assessment, and lo and behold, they'll also be hypothyroid. The other thing with hypothyroidism is it can affect your fertility, and it can affect breast milk production if you're breastfeeding. It can affect a whole bunch of things. So it's really, really important to understand that that's what the symptoms look like. I'm just trying to think if there was things that were missing. Oh, the menstrual cycles. So with hypothyroidism, and we'll get to this again, and with hyperthyroidism, because it's part of a hormone and a reproductive hormone feedback loop, if you have hypo or hyperthyroidism, it may affect your reproductive cycles because it affects production of estrogen and progesterone and follicle stimulating hormone and luteinizing hormone. So those are your 4 main pregnancy hormones, if you will. Okay, moving on to the next slide. So why you should get your symptoms treated? Well, because it sucks to have hypothyroidism, basically. I'll tell you a little bit about me. I was having some thyroid issues before I got pregnant, but in my postpartum period, I basically went from being hyperthyroidism and having significant postpartum anxiety to being very, very hypothyroidism. I gained about 30 pounds in the first year after I had my baby, after losing all my baby weight. And when I returned to work after the first year, I just felt like I couldn't function. I had that brain fog and that whole thing. So my reason for having hypothyroidism was different. I actually had thyroid cancer. But for other people, it's really the time of being in the postpartum period, because your body's trying to reset after having a pregnancy and after feeding a baby. So it could be a short-lived problem. For some women, after they've gone through their postpartum period, it will resolve and they may go forward without any issue. But for others, it will stick around. It also could be a Hashimoto's that has started in the postpartum period too. But you do need to have a discussion with a provider that understands thyroid and knows what they're doing, because these symptoms can really affect your quality of life. A lot of times we're told that these symptoms are other things, and they're brushed aside because they're typical women problems, which I hate the fact that happens, that, oh, you're going through menopause. Well, actually, you may be, but still, it's important to get treatment. And then oftentimes we'll chalk it up to work stress or life stress, or, oh, I broke up with my partner and now I'm feeling this way because of that. Well, actually, we do need to think that there might be a medical reason for all this stuff. The other reason why you'd want to get it treated is because if you're trying to get pregnant, or you're wanting to breastfeed, or if you're having issues with perimenopausal symptoms beyond the thyroid, it does really affect your reproductive cycles. And it can affect fertility, like I said. It can make perimenopause and menopause worse if it's not treated. It can affect your levels of pain. If you're a person that is experiencing joint pain, it could be the thyroid. And over the long term, hypothyroidism can cause cardiovascular disease. So I see some women who have had longstanding hypothyroidism that was untreated for many years. Even with their TSH levels being off the chart, they weren't treated. And when I look at their lipid levels in their blood, they actually have high cholesterol. And when we treat the thyroid, we can actually treat that cholesterol. So over the long term, it can influence other diseases as well. With hyperthyroidism, the opposite, more the Graves side of things, we can see some women have significant bone loss and so on from hyperthyroidism. So it's very, very important for our long-term health to have these problems treated. Did we want to just quickly stop to talk about the symptoms then? If I haven't answered people's questions, then we can maybe address some of those symptom questions now, if that's okay, Rachel?
Yeah, that sounds great.
Okay.
I think you've addressed a lot of them, actually. And
yeah, I think the only one was maybe around vision changes. So if a person's wanting to tell me more about what's happening, a lot of times with hypothyroidism, women will talk about the fact that they are requiring glasses or a frequent changes to their prescriptions. That could be partly untreated hypothyroidism. And on the other side, it could be hyperthyroidism, where it actually affects the physiology of the eye. So depends on what the diagnosis that person might have. That's the experience that you might have.
Okay, well, I'll watch to see if any additional comments.
Yeah.
But I think that's good.
Okay.
There was a question, though, around if you have any advice on how to ask your doctor for this test and how to deal with resistance, and that was from Anna Ward.
Okay. Yeah, we'll get into that next. So if you go to the slide that's a thorough assessment, this is a hard discussion to have with a provider that may not be open to having a discussion. And I'm not going to physician bash, because it's not just physicians. Lots of nurse practitioners are also not willing to look at thyroid care. But we do know that, like I mentioned earlier, a lot of people just don't understand that the ranges that are on our blood work results forms and that we're taught in school are not reflective of real life. And I'll use pregnancy as an example. when a woman is trying to achieve pregnancy or to maintain a pregnancy, her thyroid levels are ideally around 1 to 2. If you look at the range being from 0.2 to 4 as normal, some women actually will have multiple miscarriages at the higher end of that normal range. So if we treat the thyroid well, then they may be able to maintain a pregnancy. It might just not be just the thyroid, it could be other reproductive hormones that are in that picture. But it's really, really important to understand that that range is just a range and it's more of a suggestion rather than true number. Most women, from my experience and from the experience of people who do this, especially throughout North America and Europe, is that women feel better with numbers lower than 2. So if you're sitting at 3.2 or 3.58 or 3.9, which is the high end of that normal range, just because your TSH looks normal doesn't mean that you feel your best. And for people who come to see me and other people that do bioidentical care, actually, we tend to get women even below 1. So we feel much better at that range. So to have a discussion with your provider, you want to be going in understanding that there's 4 things that need to be included in your blood work. It's also a good idea to have them check your reproductive hormones at the same time. As long as they know what they're supposed to be looking at, then that's also helpful. So you want to be checking your TSH, or your thyroid stimulating hormone, the free T3 and the free T4. So the thyroid hormones that are circulating in your blood and available to do its job. And then you also want to be checked at least once in your lifetime for anti-TPO, which is the thyroid antibodies. So that would be an indicator if you had something like a Hashimoto's or an inflammatory process that had affected your thyroid. To have that conversation, what I would say is ask, tell them why, say that you were reading, and yes, people don't like that we go on Google, but or you could say you attended a conference or something and that you were learning that this might be something that you need to know about. If you're still getting resistance, my suggestion would be find another provider. There is absolutely no reason why you should have to be fighting with your family doctor in order to get care. And as my husband always says, they are government employees, so really you should be getting what you need from them. Suggestions would be to see a naturopath, see a nurse practitioner like myself who has interest in this sort of work. You can ask for a referral to a different doctor. You can go to a walk-in clinic. Sometimes that's even a better option. But specifically around a full assessment, the other things you want to be making sure are done is that the physician or the provider should be doing a thorough history. So with the symptoms that you're experiencing coupled with the blood work, along with your family history, because sometimes this is genetically present in families. Your sisters or your aunts and your mother may have had thyroid issues, which should tell the provider that this is a possibility for you. Should also be part of that history. And then a full review of your systems. So how have you been passing your bowel movements is a really important thing to ask, because a lot of women have hypothyroidism, have significant constipation, and that would help to put a full picture together. Are you having issues getting pregnant? Are you having issues with sleep? Are you having issues with getting up in the morning or making it through the day? All of that should be assessed as part of this process. You should have a physical exam at least annually, but as part of this, looking at your thyroid function, you should have your blood pressure checked, your heart rate should be listened to, okay? And as well, they should palpate your thyroid. Sometimes if women do have issues with their thyroid will actually become bulky or have nodules on it. And so we want to actually touch the thyroid and feel what's going on. And if there is bumps and lumps and that sort of thing, the next step would be to have an ultrasound of that thyroid done as well. So I can't really give you better advice around talking to your provider, except just be adamant, and if you're not going to get anywhere, then find someone else to see. You may have to pay out of pocket to see a naturopath or a nurse practitioner, but I think for most of my patients anyways, I think it's worth it. It's sometimes a very simple diagnosis and you get quick treatment. So if you could change to the next slide. When you're looking at blood work results, depending on what's happening with your thyroid, you could have an elevated TSH, which tells me you have hypothyroidism, and low T3, T4. If you have hyperthyroidism, you have low TSH and high T3, T4. Some people will have an elevated anti-TPO, which is the thyroid antibodies. And we also want to check that there's no other cause for this problem to be happening. So we would want to look at your pituitary health because it's part of that feedback loop. And I also do tests for the parathyroid to make sure that the parathyroid's functioning as well, because it's a supportive gland. It helps the thyroid to work. So if there's an issue with the parathyroid, that needs to be ruled out as well. If you can just change to the next slide. So as far as treatment options goes, there was a question about the treatment of hypothyroidism. So we'll talk about that. The typical treatment for hypothyroidism in the last 30 to 40 years has been something called levothyroxine, which is a synthetic thyroid hormone. And it's sold as Synthroid. It works great for people who have non-inflammatory thyroid problems. And it's a really good drug because it provides the same amount of T4 only every day. And it gets your body to have a specific level of T4 so that you can function and your body can function. And it sounds like for Rachel, Synthroid worked great. And for a lot of people, it works really well. For people who have inflammatory hypothyroidism, so for Hashimoto's patients, sometimes the natural or the desiccated thyroid works better because it provides both T3 and T4. Why that's important is because with Hashimoto's, as with Graves', the thyroid gland itself is not working properly. There's been damage to the thyroid, and oftentimes that damage will result in the body not being able to produce T3 from T4. And if you remember at the very beginning of my presentation, I said 80% of the body's T3 comes from the T4, not from the thyroid. So if your body can't make T3 out of T4, we have to give it T3. And the only way to do that is through this natural or desiccated thyroid. The natural thyroid comes from a pig. It's the closest thyroid hormone that you can get, besides taking it out of someone else, which isn't possible. And so yes, it works really, really well for many people. I do not have a preference when I'm prescribing one versus the other. Honestly, I'm open to prescribing anything to anybody, and we just give it a try and see what people like. There is another treatment that's becoming more popular. It's called Levo-Lyo, which is synthetic T4 and synthetic T3 given separately rather than in one pill, and we basically dose based on the body's response. That would be available for a person who has a very, very high level of antibodies in their body, because it really, those high levels of antibody affect whether our body can even use the T3 and T4 that it's given. So we would balance it that way. There's also many non-pharmacologic options, including acupuncture, and naturopaths can offer mineral and vitamin supplements and other treatments that may be helpful for thyroid health. For those who are experiencing hyperthyroidism, like I mentioned before, this is something that needs to be treated urgently. We use something called methimazole, which is the chemical name for the drug, in different doses to contain the thyroid from overproducing T3 and T4. If that doesn't work, we treat with radioactive iodine or surgery. There's no non-pharmacologic treatments that are appropriate for a hyperthyroid state. Most of your naturopaths, etc., will not treat because it's more of a medical emergency than it is anything. The other thing I would also say is that anyone who has a thyroid issue should be making sure that they're taking care of their body, like I talked about in the menopause discussion. Exercising, eating as clean as possible, and making sure you're taking vitamin and mineral supplements that are appropriate, and particularly vitamin D is really, really essential for parathyroid and thyroid health. So women should be advised around how much they should be taking of the vitamin D as well. Okay, the last slide. We're not going to advertise our services, but please reach out if you're not getting the care that you need from your family physician, either through a different provider, a naturopath, a nurse practitioner, acupuncturist, someone else that might have a bit different expertise. And if you're having really big issues with your thyroid, you can even get a specialist referral to an endocrinologist. So my alarm went off, so it's time for me to stop talking. If we want to turn to questions, I'm really excited to hear what you guys have to say.
That's great. Thank you for the presentation. We definitely had a lot going on in the chat and a lot of questions coming through continually.
Okay, good. Great.
So I'll just make my way through them based on what was asked first. The first one is from Erin Dirksen, and she wants to know, what do you do when your blood work looks good with medication, but you still have symptoms?
Okay, so that's a really good question. It depends on your provider's comfort level and where you are in your lifespan. So for a lot of my patients, I will treat them to their feeling. And that would be the recommendation of many people who do this sort of hormone work. So if you're still feeling sluggish, you're still feeling, cold, and you're not able to exercise and getting all those hypothyroid symptoms, there probably needs to be an adjustment made. And also the other thing I would ensure is that you don't have an inflammatory reason for your thyroid problem. Perhaps that went undiagnosed, and maybe treatment with a different treatment would be helpful as well.
Great.
So hopefully that helps.
Yeah, that's great. What are your thoughts on desiccated thyroid treatment? So you touched on this a little bit, so just wondering if you have anything further to say about that, and I'll leave that to you if there's anything else that
Sure. I think the key here is that knowing that the typical prescription or treatment that the medical profession will suggest is Synthroid, and the literature or experts say that there isn't enough literature about the value of desiccated, when in fact desiccated was used for many, many, many years before synthetic Synthroid was made available and to effect. So there's becoming more and more studies that have been published from Europe, and they are available about the value of desiccated, specifically around for women who have inflammatory thyroid problems, but also for people who are going through perimenopause and who are menopausal or postmenopausal. Because it once you actually get the right dose, you can balance your thyroid health just like you would Synthroid. It's faster acting, and it goes out of the system faster as well. So if you wanted to try it, it's a very easy therapy to introduce. It's just a matter of finding a prescriber that's comfortable with that kind of back and forth frequent visits that you would need to have in the first couple weeks. Usually what I do in my practice is if a person wants to try desiccated, or that's my recommendation, I'll put them on a low dose of or a starting dose of desiccated for 2 weeks. And if they're feeling great, then we leave it. If they're not, I up the dose. And then we just kind of go from there to determine whether or not they're feeling better. Sorry, that was
great. So another question that we have is an interest in hearing more about bioidentical care.
Okay, so we talked about bioidenticals a little bit last session, but basically with bioidenticals, the options for women are few in the city, but you basically find a provider that prescribes or does bioidentical care, which involves assessment and then treatment based on your history and your symptoms, as well as your blood work. And basically what we would look at is thyroid and all your reproductive hormones. So progesterone, estrogen, testosterone, and FSH, LH. Perhaps referring to the other presentation might help people. But basically what we do is we treat thyroid, we treat most women will go on desiccated with progesterone and testosterone to start until they go through menopause, at which time we would then add in estrogen. There's also other therapies that you can be offered, including pregnenolone or growth hormone or oxytocin, depending on the symptoms that you have. The bioidentical nature of the therapies is that they're plant and animal-based versus synthetic. So they are more like our body's natural hormones. Hence, we get fewer side effects, and they're metabolized much easier. So that's a short and skinny of bioidentical hormones. My practice is specifically focused on fertility, thyroid, and menopause, and most of the treatments that we offer are include bioidenticals. So if you're interested in that, we can have a discussion at another time for sure.
Great, thank you. Lula Zakaria is wondering, is there a connection between thyroid disease and other autoimmune diseases such as arthritis?
Absolutely. So if your body is inflammatory prone, so you have arthritis or you have lupus or you have had some sort of inflammatory disease, then it can affect your thyroid. It doesn't always, but it can. So if you have a rheumatologist that you're already working with that's diagnosed your arthritis, you could have that discussion about your thyroid health with that person. But certainly if you've had an inflammatory response in your body and it's affected your thyroid function, then of course your thyroid could be related to that. Hopefully that makes sense.
Yes, I think it does. Okay. Can dental issues be related as well?
Dental, it could be. It would be more of a roundabout way. So in fact, if the thyroid was affecting production or use of other reproductive hormones, and or there was a problem with the parathyroid in particular, then your body might not be utilizing vitamin D and calcium, and it could affect your teeth. It could also affect the red blood cell production, which could cause bleeding gums. So it depends on the symptom, but physiologically, the thyroid is looped into every other female hormone. And female hormones affect calcium, they affect magnesium, they affect every other electrolyte and mineral in your body. So absolutely it could.
Okay, that's good to know. There's another question that's come in around what is the role of a nurse practitioner? This is something that some of our participants have heard about, but they're not really sure what the difference is between them and a doctor and what their role is in this story.
Okay, awesome. Thanks for asking. I don't usually normally talk about myself because I know myself very well, but absolutely. So a nurse practitioner is a registered nurse that has a master's degree or a PhD. In clinical nursing practice, we have an expanded scope, so we can diagnose, prescribe, order anything we need. Basically, we work like a family doctor, but more like a nurse. So we spend more time, tend to do a lot more teaching, and we're paid differently. So if you have a nurse practitioner that works and is paid by Alberta Health, then they are salaried versus having to bill the government for every 5 to 10 minute appointment they have, hence why we can take more time with our patients. For myself, I have a private practice, so I'm paid out of pocket. Most insurance companies will reimburse for my time because I'm a nurse. So if you're interested in seeing a private nurse practitioner, there's a few of us around the city. That would be how you could go about it, either through your physician's office who may have a nurse practitioner. There's nurse practitioners that work in acute care, and then there's private NPs as well. So hopefully that helps to just differentiate from what we do from other people.
Yes, and I realize that we could probably give our provider a call before using your services if we're curious.
Absolutely. I would say you're connected with your family doctor. They know you better than anybody, and you're paying for their service. So you should absolutely start with your family doctor. If you're unattached or you're having trouble finding somebody, there's a couple of websites available that can link you up with primary care providers that are taking new patients. If you're lucky enough that you're part of a primary care network, your doctor's office is part of the PCN, there are NPs that work in the primary care networks as well, so you could even ask to speak with a nurse practitioner. We're having our annual conference coming up in April, and so all the NPs that are able to come to the conference in Edmonton will be hearing about menopause care because I'm doing a little talk. So hopefully they'll be available to help you explore thyroid and perimenopause and all that sort of stuff. And then if you're still not getting anywhere, like I said, naturopath would be a great person to start with, or someone like myself. There's other specialists that you can access through your family doctor. If your family doctor's not sure about what's happening with you, you would ask for a referral to an endocrinologist.
Great. Now there's another question that came in from Tracy McBride wondering what are the normal ranges of antibodies?
Okay, so as long as your antibodies are under 50, that's considered to be normal. It depends though on what antibodies you're talking about. So if you're just looking at anti-TPO, which is the antibodies to the thyroid hormone, that would be under 50. There are a whole bunch of other things that can be ordered specially, but generally the anti-TPO would be the one we would start with, and if it's under 50, that's considered to be normal. I have some patients that have come to me and they've been right in the middle of a new Hashimoto's, and their antibodies have been up as high as 500. Others that have stayed and hovered around 130. So the range is, you know, it's really not possible to say how high an antibody could go, but you want to keep it lower or non-existent. And you can't really do much about that. It's your body's response, actually.
So as a follow-up question for myself, actually, having gone through the different levels of Synthroid and then checking my blood work as I've gone, the numbers that I've been hearing are that I am between, well, now I'm at a 2 is what I've heard. So
okay,
what is that number then?
So that's your TSH.
Okay.
So that's your thyroid stimulating hormone. And that's what typically people look at. Now, if you still weren't feeling great, then you could have that your Synthroid adjusted. But the other thing with, and I don't know your reasoning for your hypothyroidism either, Rachel, but the other thing would be to just ask if you could get your T3 and T4 checked. I imagine your T4 would be fairly high. Your T3 might be in normal range, and that's great because you're on Synthroid, and as long as you don't have anything else going on and you feel better, then wonderful. But again, to get that full picture, we really need to be doing the TSH plus the T3, T4. Some family doctors will only order the TSH and the T4, and that's also fine. But if you're still not feeling well, then that T3 is a really important number to look at. Sometimes with Synthroid, because you're getting only T4, you'll get higher levels of T4, and your T3 will kind of stay low. So if you're still getting fatigue and you're still feeling that brain fog and you're not kind of feeling as good as you'd like to, then maybe looking at a way to elevate the T3 a little bit might be an option.
Great, thanks for that.
Your family doctors are going to hate me for telling you all this because nobody likes prescribing desiccated. I don't know why, but.
Okay, well, that's great. I will probably take that away and ask my doctor about it.
Yeah.
Another question that came in is, are leg cramps related at all?
Sorry?
Are leg cramps related?
Okay. That's a good question. It sometimes can be. It's part of that joint and muscle soreness that can happen with hypothyroidism. The other thing I would get checked, if it's particularly happening later in the day or when you're trying to sleep, have your magnesium levels checked. Sometimes taking a magnesium supplement of 100 to 150 per night will take away those muscle cramps. Exercising, so they start exercising in about 15 to 20 minutes, they're completely exhausted. That would be another sign of hypothyroidism. In and of itself, if that's the only thing you're experiencing, probably not the reason, but if it's coupled with a bunch of the other symptoms, then I would look at thyroid for sure. But muscle cramps, especially at night and when you're trying to sleep, it's probably partly your magnesium.
Okay, that's great. Thanks for the tip.
No problem.
And another question that came through is, what would the abbreviation be on the lab request form? So they saw their doctor and obtained a lab test for THS, T3, and T4, but they don't see the antibodies checked off anywhere.
Okay, so if you have the blood work form in front of you where the TSH is ticked off, if you look just up in the next box above it, it says anti-TPO. And that's where it should be. Now I was just looking to see if I have one in my bag, but I don't. Yeah, it should say anti-TPO right on there. And it's above the TSH. So
great.
Hopefully you can find it.
Awesome. And are there alterations to lifestyle that can aid with hypothyroidism, things like specific diet, supplements, etc.? I know you mentioned vitamin D being really important. Is there anything else?
So usually what I say when I do talks or I talk to patients about their diet, one thing I try to caution people on is not to do the diet trends or to try any of those crazy things. They're not necessarily crazy, but you can't fix your thyroid by doing keto, for example. We don't think. Having said that, clean, yes. So we know that the more fruits and vegetables, lower amounts of saturated fats and animal fats is better. For people with inflammatory thyroid problems, oftentimes they will do better when they're not eating a lot of gluten. So some of my patients will go gluten-free, and it makes a significant difference. Other people will do better also off of dairy because they tend to be inflammatory, allergic, stimulating foods. It's not the actual gluten that's always the problem. It's what we do to our grains that causes the problems. So if you can find healthier grains, you probably don't have to go gluten-free, but you need to be, it might be good to watch that. So if you have Hashies or Graves, a lot of my patients, like I said, will do the gluten and dairy free stuff. I have had patients do keto. It's a very, very, very difficult diet to follow. And we don't know the long-term effects of keto diets. So I'll just leave that out there. I have other people who have done paleo, and I'm just knowing, I have a really long background in exercise, health, and as well as medicine. And I'm just a little bit leery about all that animal fat that we get. So just be cautious about the fad diets. Eat as much healthy grains, vegetables, fruit that you can. Mediterranean diet is always advisable if that's something that you know about. And that's all really we can say at this point. Then we know there is a few studies that are going on in Europe around the relationship between gluten and thyroid. So hopefully we'll get some results in the next couple of years.
Great. I think that's all the questions that we have at this point. So lots of great discussion that went on in the chat.
Good.
I don't know if there's any last comments or kind of last thoughts you'd like to leave the group with today, but over to you.
I think the only thing I would just say is to caution you or to be prepared for some resistance from your providers. Don't take it personally. Sometimes with my patients, even when they're getting blood work done for me around their perimenopause or their thyroid, their family physicians get those blood work results. So just be prepared for that discussion, even if you go outside of your family doctor's office to get care. Because of NetCare, which is our shared lab and computer system, your family doctor will get any results that you've had requested for you. So yes, just be as open as you can, and hopefully you'll be able to find somebody that can listen and understand what you're going through. And don't let people brush you off.
Yeah, that's it. That's great advice, and I can empathize with that, as I had to go through that a little bit myself, and I'm happy to have a further conversation with anyone that's been participating today about my journey. Also, please join us for part 3 of the Ellevate X Wellness event series, which is on April 16th, and it will be about fertility.
Mm-hmm. Excited to talk to the group about that. Another passion.
Great. Thank you. Have a great day, everybody.
Thanks, everybody.
Bye.
Thanks, Rachel.